Oh, good morning, everyone. It's a pleasure to be here. So I was lucky enough last night to do some fat biking in Gatineau at 9:30 after I flew in and gave a talk, which was a lot of fun, actually. I did not crash, which is very important. I didn't want to turn up today looking scarred and bruised. So what I thought we would do today is really focus on diabetes and cardiovascular disease. I'm not going to spend a lot of time going over in detail all the clinical trials and so on. I'll give a summary, and then what I'll do is really go on to some more practical tips of how we can incorporate the use of many of these not so new agents now into the practice of cardiovascular clinicians. So when it comes to disclosures, here are my disclosures. The most important one is that I'm an Australian and that my grandparents were convicts, and that's how I ended up in Australia though. So when we think about diabetes, clearly it's the diabesity epidemic is really the epidemic of the modern era. These are the international statistics. You can see here we have somewhere like 425 million persons with diabetes currently, projected out to 2030 to be in the order of 550 million people, roughly out of 7 billion people. So, 1 in 12 persons on the planet has diabetes. And if we look at what most people with diabetes actually die of, and it doesn't matter whether you look at the so-called developed nations or developing nations, first world or so on, most persons with type 2 diabetes die a cardiovascular death. And if you ask our patients what they die of, most persons their big concerns is in fact not cardiovascular disease, it's the risk of developing the microvascular complications of blindness and renal failure. Usually when I ask patients what they're worried about, they say, "Doc, I don't want to go on the dialysis machine. I don't want to become blind." But as I said, unfortunately the statistic is that it's really about 75% will in fact die of cardiovascular disease. And if we look more specifically in Canada, these are the sort of overall numbers. You'll see about 1/3 of all persons who present with an MI will have type 2 diabetes. 40% who present with heart failure will have type 2 diabetes. 2/3 of non-traumatic amputations, type 2 diabetes, and about 50% of all patients who start dialysis will have diabetes. So overall, when we look at the causes of death in Canada, 1 in 10 deaths is now a direct result of type 2 diabetes mellitus. And really for the main focus of the talk, I will be talking about type 2. Now, it's not to diminish the impact of type 1, but it's really type 2 is where the main burden of disease is currently. And with this, it's an expensive condition. So we're talking billions and billions of dollars spent on monitoring and treatment of this condition. But one of the questions that I'm often asked about is, well, I'm a CV doc, why do I need to bother about it? This should be treated by primary care physicians. This should be treated by our endocrinology colleagues. Unfortunately, I think that's just really not the case anymore. If we think about it, as I've already mentioned, about 40 to 50% of all patients with cardiovascular disease have diabetes. It worsens the impact of all cardiovascular risk factors. It worsens the outcomes of all cardiovascular syndromes, and it really impacts everything we do. Whether or not you see a person with atrial fibrillation, if you think about the CHADS-2 score, the D stands for diabetes. You get a point, you're on an oral anticoagulant. Whether or not you go to the cath lab, you have triple vessel disease, it determines the impact of the revascularization strategy. You're much more likely to suggest that that person should go for bypass as opposed to PCI. It impacts our targets. If the person has type 2 diabetes, we say that the appropriate blood pressure target should be 130/80. So there's no doubt that we need to come up with strategies that cardiovascular docs actually take this and move it forward. What's interesting though, is if we look at the Royal College Physician syllabus for cardiovascular docs, I don't know what all that noise is coming from, so I don't know if you can hear it. Excellent. Okay, good. So now I've lost my train of thought. Thank you, Sandy. No, but as I was mentioning, if we look at the College of Physicians syllabus, in your cardiovascular training, the amount of specific time that you need to spend diagnosing or learning about diabetes is absolutely zero. That's right. Okay, good. So I should just shout the rest of the lecture and then you'll hear it there. Anyway, maybe I'll just let you read all the slides themselves. But yeah, but so there's no doubt that unfortunately there's been a little bit of a disconnect between how important it is on our cardiovascular practice and that we have not really been exposed to it during our training. And this is sort of my trying to come up with a simple way to understand why. For many years, we have known that the strategy of reducing glucose using agents such as metformin, insulin, sulfonylureas, there's no doubt that it reduces the microvascular complications, retinopathy, nephropathy, and neuropathy. And here's the data here in both persons with type 1 diabetes, you'll see in orange here, and in type 2 diabetes with the major clinical trials, UKPDS, Advanced, VADT, and Accord. And you'll see that overall, clear reductions really in nephropathy, neuropathy, and retinopathy. Not always consistent, but I think the overall message is, yeah, we've been very successful in reducing microvascular complications. And there's probably a good reason for that. If you think about the tissues like the kidney, like the eye, like the nerves, they are exposed to the ambient glucose concentration. The higher the glucose, the more glucose will diffuse into those tissues. Therefore, it makes sense that if we use an agent to reduce glucose, there will be less direct glucose effect on those tissues and you'll reduce the complications. If, however, though, we switch it around and think about macrovascular complications, MI, stroke, you'll see here that it's been not the same story, that we have really made very minimal impact. And in fact, one of the trials, the Accord trial, which looked at the strategy of intensive glucose control compared to sort of less aggressive glucose control, there was actually a significant increase in cardiovascular mortality. So overall then, from the practicing cardiovascular condition where we're more sitting in this space, it's not surprising then that people say, well, we don't have any specific therapies that modify outcomes. Why do I need to spend my time learning about it? But clearly the landscape has changed and evolved, and that's not the case anymore. So if we think about a number of years ago, the FDA in their wisdom turned around and said, okay, because macrovascular disease is such an important endpoint in cardiovascular disease, you need to design trials to at least demonstrate that the so-called newer agents are safe in this setting. They don't have to necessarily be superior in reducing cardiovascular outcomes for those macrovascular complications, but we clearly need to show that they are safe in that setting. And because of that now, in fact, the assessment of persons with type 2 diabetes for macro and microvascular complications is the second most intensively studied area of medicine after the broad general cardiovascular community. And you'll see here that what I've done is divided that up into the sort of three overall categories where these so-called non-inferiority trials demonstrated safety with various classes of agents, and you'll see that's the middle point, which are the DPP-4 inhibitors, insulin and thiazolidinediones. And when I say safety, it was that these agents demonstrated safety as regards to major adverse cardiovascular events, which was the definition of cardiovascular death, non-fatal MI, or non-fatal stroke. We look at those agents where there's clear demonstration of cardiovascular superiority, and the two classes there, you'll see the GLP1 receptor agonists and the SGLT2 inhibitors. So in regard to the GLP1 receptor agonists that we have liraglutide, dulaglutide, semaglutide, and obviously the SGLT2 inhibitors, empagliflozin, canagliflozin, and dapagliflozin. Not in any particular order in this table here, it's just that's what I've done it as per when the trials were reported out. And then we have a number of agents that we don't really have any particular safety data as yet. And what you'll see here is that there are differences in these agents when we look about them in regards to their impact on HbA1c lowering, the risk of hypoglycemia, heart failure and blood pressure effect, and we'll go into a little bit more detail in those. There clearly was a signal with one of the DPP-4 inhibitors. saxagliptin, which saw a 27% increase in the endpoint of hospitalization for heart failure. But other than that, the other agents in that class have really shown overall neutrality for that endpoint. So it was really only a standout signal for saxagliptin. And I'll talk a little bit about hypoglycemia and how important this is later on, and really not so much importance of trying to use agents where we can avoid it, because if you have significant hypoglycemic effects, it is associated with adverse outcomes. So if we look then at the sort of conglomerate of the major clinical trials that have reported out so far, you'll see here that with the SGLT2 inhibitors, that there was a reduction for the MACE endpoint with the empagliflozin and canagliflozin, and in the DECLARE trial with dapagliflozin, this did not meet the MACE endpoint, but it was positive when we look at the endpoint of reduction in hospitalization for heart failure and cardiovascular death. And then you'll see when we look at the individual endpoints here, there wasn't really any particular signal that this reduced non-fatal MI and non-fatal stroke. Most of the endpoint was driven by this significant reduction in hospitalization for heart failure. It's also important to note that as we move from the empagliflozin through to canagliflozin, that here we go from, with EMPA, this was all patients with established cardiovascular disease. It was about 2/3 of the population in the CANVAS trial here had established cardiovascular disease, and about 1/3. So as we go, if you will, from the EMPA to DAPA, the patients were, I don't think we can say they're less sick, but they did not have as much established cardiovascular disease. If we look at the GLP-1 receptor agonists, we have the liraglutide, semaglutide. I've put the data here in for oral semaglutide, which is just reported out, and dulaglutide. And using these agents, because these are all available in Canada currently, you'll see that we see slightly different effects in that these met the MACE endpoint with liraglutide, semaglutide, and dulaglutide. But what we see is this significant signal in non-fatal stroke. So if we will, this is sort of the best case scenario when we're thinking about the endpoints of treating our patients with diabetes. We have SGLT2 inhibitors which seem to affect the cardiorenal axis here with the endpoint of hospitalization for heart failure, and we're seeing this non-fatal stroke signal and, if you will, sort of an anti-athero effect with the GLP-1 receptor agonists. So we'll sort of break it down and go into a little bit more detail in terms of the SGLT2s versus the GLP-1s, but I think for our patients this is the best case scenario, because now we have agents that have clearly modifying different important outcomes that type 2 diabetes affects. And if we break it down a little bit further, again, I mentioned before, as you look at the SGLT2 inhibitor class, you'll see that there is different effect in those persons who have the so-called established atherosclerotic cardiovascular disease and those that have cardiovascular risk factors alone. So again, looking at the endpoints of cardiovascular death, non-fatal MI, and non-fatal stroke, you'll see that there were significant reductions there in those that have established atherosclerotic disease, where overall, if we look at the hazard ratios in those that have risk factors only, you'll see that it's really on 1. So again, as you go from this so-called primary-secondary effect, there is an overall differential effect. But what was more consistent there was that we saw that regardless if you're in the primary or secondary group, that this reduction in hospitalization for heart failure still remained. So I think this is important when we think about, well, exactly which persons will you treat with which particular agent. You need to look at the risk and then determine which agent that you may consider for that particular indication. So what do we have for guideline recommendations currently? So this was the 2018 Clinical Practice Guideline Update from Diabetes Canada. There is a new update that's coming forward. The way in which Diabetes Canada do the guidelines is a big group meets, and then every 5 years the guidelines get updated. So it's a little bit behind the times. It's recognised that it is. However, they've changed the way they're going to do it moving forward so that it'll be a little bit more nimble. And that's why we've only have empagliflozin, canagliflozin, and liraglutide in this current schema. So what it says, in adults with type 2 diabetes with clinical cardiovascular disease. So here the indication was for those with established cardiovascular disease in whom glycemic targets are not achieved, which is generally an HbA1c greater than 7%, with existing anti-hypoglycemic medications, and EGFR greater than 30, that an anti-hypoglycemic agent with demonstrated cardiovascular outcome benefit should be added to reduce the risk of major CV events. EMPA, liraglutide, Cana, heart failure hospitalisation, EMPA in Canada, or the progression of nephropathy. So as I said, this is being evolved now and will really update to involve dulaglutide, semaglutide, and dapagliflozin as well. So we're seeing this evolve as time goes on. We will also be seeing a Canadian cardiovascular guideline update. It's at the moment, it's being in the process of being written. Hopefully it'll be ready to be reported out by Canadian Cardiovascular Congress in 2020 to give a bit of a spin from the cardiovascular perspective, but of course that's going to be done with Diabetes Canada, the Canadian Society of Nephrology, so that we have an overall very appropriate recommendation, but it will be mandated through the CCS. Now, interestingly, that's the sort of Canadian landscape. What have others done? So what are other major regulations done based on the data I've shown you to suggest how we should be using these new agents? And I put this in, this is the ESC update. So they did a little bit of a controversial thing. There was the European Society of Cardiology in collaboration, and the wording here is important, with the European Association for the Study of Diabetes, the EASD, which is a bit like the American Diabetes for the European group, and they changed the way in which we think about moving forward. They've said, okay, given that cardiovascular complications are the key endpoints that persons die on, that's what we should be understanding, and that's what should drive therapy. So they classified then persons into those that are at very high risk, so patients with diabetes and established cardiovascular disease, or target organ damage, or 3 risk factors, or early onset type 1 of long duration. Those that are at high risk, patients with diabetes duration greater than 10 years without target organ damage, plus an additional risk factor, or those that are at moderate risk. And then they said, first calculate the risk, then determine the therapy that should be utilised. And I like this schema because that's a little bit similar to what we do at the moment. Patient comes to your office, you do a Framingham risk score, some sort of risk score, and then that's going to determine, based on their 10-year risk, which therapy you're going to consider. Statin, blockade of the renin-angiotensin system, so on and so forth. There we go. So what they did here though was a little bit different. They said, okay, if you're in type 2 diabetes and you're drug naive, so you have not yet been commenced on an anti-hyperglycemic agent, you'll then assess the risk based on the schema I just mentioned, and then you can go directly to avoiding metformin, an SGLT2 inhibitor, or GLP1 monotherapy. If they're on metformin and their HbA1c is on target, then you would say, okay, we should then, as second line, use an SGLT2 inhibitor or GLP1 receptor agonist. Now, the clinical trials that were designed to look for safety were all done generally on the background of at least metformin monotherapy. However, the EASD, ESC said, well, actually the data for metformin alone is fairly weak. What we do, however, is have very strong data for SGLT2 inhibitors or GLP1 receptor agonists, so we think that they should be utilised first and foremost. Now, I mentioned that the ESC document was done in collaboration with the EASD because there was a lot of controversy about this, and at the last minute the EASD almost walked away and said we refuse to endorse these guidelines because we believe metformin therapy should be first. And I put that in because we don't actually know what the Canadian landscape's going to say at the moment, but I think it's trying to get to the point of, well, which agents do we have with proven cardiovascular benefit, because they're the agents that we actually want to focus on. Now, if we have patients who are on metformin already, well then it's simple. You would then add an SGLT2 or GLP1 receptor agonist after you've determined the cardiovascular risk and move forward there. So you can see there is a bit of controversy. It's going to be interesting to see how things move forward at the moment. The Americans have said really metformin first line and then add an SGLT2 or GLP1 receptor agonist afterwards. So we'll have to see how the Canadian landscape interprets the data there when we write our own guidelines. Now, that's all the sort of theory. What about the practical, day-to-day? How do we initiate these drugs? What are the overall differences and similarities between them that we should consider? Well, clearly, if we think about the SGLT2 inhibitors, these are oral medications that we take once daily. You'll see the doses there with EMPA, 10 or 25 milligrams, canagliflozin, 100 milligrams or 300 milligrams, DAPA, 10 milligrams. We have the injectable agents, liraglutide, once daily, semaglutide, once weekly, dulaglutide, once weekly there. You'll see there are differential costs with this. Semaglutide, trade name is Ozempic, is now covered under the ODB for persons greater than 65 years of age. You'll see the other important differences there over and above cost is that there are GFR cut-offs for the class of agents, the SGLT2s. At the moment, EMPA and Cana can be used down to an eGFR of 30, whereas dapagliflozin, the product monograph, is down to 45. This is likely to change over the next little while as we get more data, but this is what it is at the moment. Whereas the GLP-1 receptor agonists, you can use down to eGFR greater than 15. You can probably use them lower than that. We just don't have a lot of clinical data to support how we should be using them. The other difference is that there are differential effects on weight loss. You'll see here that on average, the SGLT2 inhibitors, we get somewhere around 2 to 3 kilograms in weight loss because you pee out all the sugar, so you're not converting it into fat. Whereas the GLP-1 receptor agonists, again, you see slightly greater weight loss, but semaglutide, there is generally substantially more weight loss in the order of 4 to 5 kilograms. There is a preparation that is available for oral semaglutide. There are 2 clinical trials being undertaken at the moment to look at those cardiovascular outcome trials. It'll be a number of years before they report out, but obviously there is going to be an oral GLP-1 receptor agonist available. There's also differential effects on blood pressure, with the SGLT2 inhibitors having somewhere around a 5/2 millimeter reduction in blood pressure. The GLP-1s are slightly less, 2 to 3 millimeter of mercury reduction in blood pressure. So this is going to be important when you think about the person who's sitting in front of you as to which agent you may consider, depending on if weight loss is your primary goal, if blood pressure lowering is your primary goal, and knowing their renal function. And then, as I mentioned before, the other factor is, are you going for the sort of cardio-renal axis? Are you thinking about heart failure, renal protection, or are you thinking more about, I want an anti-athero effect, with the cardio-renal axis being preferentially affected by the SGLT2 inhibitors and the GLP-1s more having that anti-athero effect that I mentioned before. So what are the adverse effects that you need to know about? Because I think with the SGLT2 class, there are a few things, you need to take a few minutes to describe these to the patients. Because you're peeing out the sugar, the urine is full of glucose, you are more predisposed to genital mycotic infections. And I can tell you 5 or 8 or 10 years ago when this first class of agent was proposed, we laughed and said there is no chance anyone is going to take a drug that causes genital mycotic infections. Patients don't seem to care. I can tell you, you tell them about it and they go, yeah, who cares? I lose 2 to 3, 4 kilos. I feel better on the drug. It's not been an issue at all. It occurs in somewhere like 5 to 10% of patients. There are a number of other side effects, potential side effects. These really fall into the rare category. These agents do not predispose towards upper urinary tract infections. That's been shown in really all the major clinical trials. They do have that blood pressure lowering effect. However, this is really mild. They tend to protect from acute kidney injury. They do not cause acute kidney injury. They do cause, and this is an important point, they are associated with the development of diabetic ketoacidosis. They do not cause it per se. Diabetic ketoacidosis occurs where there's an imbalance between insulin and glucagon. So generally what happens, you become unwell, someone does not take enough insulin and there's excessive glucagon, and it's that interaction that then enables the process of DKA to occur. It's fairly easily prevented, and I'll give you some tips as to how we can do that. With canagliflozin alone, there was an increased risk of amputation and bone fractures. With the other agents, this has not been seen, and in fact, the further clinical trial data we've seen with canagliflozin suggests this is not really a major impact. So, however, the Canvas trial there was a doubling in the risk of amputations. So, Patients are going to hear about it, they're going to see about it, but it has not been seen with empagliflozin and canagliflozin, so don't need to worry about it with those two agents. With the GMI, a couple of extra points. Its greatest risk is in women, then uncircumcised male, then circumcised male. I always joke here, I'm a cardiologist, talking about the difference between uncircumcised and circumcised male. It is important to tell people that they need good genital hygiene. They just need to wash. It's not difficult, but you do need to mention it. It's only mild. It can be treated over the counter with a single dose of fluconazole, 150 milligrams, which persons can get when they go to the pharmacy. In the clinical trials, it almost never leads to discontinuation, nor does it in the real world, but because the urines, it is predisposed towards this, I think if we're going to prescribe it, you need to mention it. As I mentioned before, with the amputation risk, this was only seen with the drug canagliflozin in the CANVAS program. With other clinical trials that have been done with the agent, it has not been seen. So whether it was a chance finding in the clinical trial or not, who can say, but it's there, it's been noted. As I mentioned, not seen with empagliflozin and dapagliflozin. So if you're going to mention the drug, how do you use it? Well, you need to mention that it will make the urine sweet, and that's why they are predisposed towards GMIs, and that in certain situations you want to just tell the persons to stay hydrated. Importantly, however, if they become acutely unwell for another reason, they do need to stop the medication. And at this point in time, I think it's really only persons who have expertise in the management of type 1 diabetes who should consider using these drugs at the moment. As I mentioned before, SGLT2s, I think for the cardiovascular condition, is really only for persons with type 2 diabetes. And then how do you protect persons? Well, there's an acronym that's come up called the SANDMANS. And what the SANDMAN is the sick day medication list that all persons with type 2 diabetes should avoid. And in fact, if you think about it, this is not really a diabetics list. This is your persons with heart failure, with tenuous cardiac function for any other reason, that if they become unwell, that there are agents that they should consider ceasing. Sulfonylureas. These agents cause hypoglycemia. So if they're not eating and they're taking them, they're predisposed towards that. They should stop the ACE inhibitors, diuretics, metformin, ARBs, non-steroidals, and the extra S on the end of this list is the SGLT2 inhibitors. So although it seems like a lot, I think this is overall good advice for our patients when they become sick for another reason, they do not have adequate oral intake. These agents should be ceased. We've all seen it in summer when someone becomes unwell, they continue to take their diuretics and renin-angiotensin system, and they become acutely volume depleted and end up in hospital with an acute kidney injury. And so this advice list is fairly simple and straightforward there, but it is important that if they have poor oral intake, that they should cease the SGLT2 inhibitors. And I'll give you some advice as to what we should be doing in the in-hospital setting in a moment. What do you do if you're worried about their diuretic usage and their volume status? Well, just like you would initiating any other diuretic, there's nothing magic here. If the patient is volume contracted, you would not initiate a diuretic, nor would you initiate this agent, which will cause some blood pressure lowering. If they are clearly volume overloaded, go for it. You can prescribe the agent. Once you've looked at their volume status, then look at the blood pressure. If they're hypotensive, clearly we're not going to initiate an agent that will cause on average a 5/2 millimeter of mercury reduction in blood pressure. If they're on a thiazide, you can probably continue that if they're normotensive, and with loop diuretics you may or may not consider reducing that. And if they're hypertensive, then you can clearly use the agent. So again, just like you would initiate any other agent, you look at the volume status, look at the blood pressure, look at the renal function if you've got it. Nothing magic, exactly what we would do with the diuretic or blocker of the renin-angiotensin aldosterone system. So that's the SGLT2s. What about the GLP1 receptor agonists? So there's two clear points that need to be made here. One, they're injectable, so persons need to be comfortable with injection. It's very simple, very easy. As cardiologists, we're used to low molecular weight heparin, we're used to PCSK9 inhibitors. There's no difference here, once weekly injection, very simple. If you use sema or dulaglutide, or once daily if you use liraglutide. These agents do modify gastric emptying and are associated with nausea. So this is very important. You need to start at a low dose, slowly up titrate, and tell persons that they will develop this and that they need to modify their meals to take smaller frequent meals. Otherwise you will get quite full, a lot of fullness, and that's usually the cause of the nausea. It's self-limiting. It resolves after 2 to 4 weeks and goes away and gives you the opportunity to up titrate the drug. In persons who have clear gastroparesis or pancreatitis, we do not recommend the use of these drugs. There is a very small increase in the risk of pancreatitis. It's really in that rare category, so overall it's suggested if you've had significant pancreatitis before that we don't avoid it. And there is some suggestion that in those who have MEN2, which is associated with medullary thyroid cancer, that we avoid it. These are not big points. These are really in the very rare, but it's in the product monograph, so you should know about it. As I mentioned, the key thing is telling the person that they will have this self-limiting nausea. They need to modify their meals. And typically, as I mentioned, the simple way to do it, start with a low dose, up titrate slowly, and obviously high-fat foods will modify gastric emptying per se, so they should try and avoid that in the first instance itself. And that often at the beginning it may be more tolerable if they deliver the agent on an empty stomach, i.e. before bed. But it's very simple. There's really no rocket science to the use of the GLP-1 receptor agonists themselves. Now, importantly, hypoglycemia, what do you do with the other anti-hypoglycemic agents that they're on? So when we think about hypo, just as a point, we think about the autonomic symptoms, the trembling, the palpitation, sweating, anxiety, and then the neuroglycopenic symptoms, obviously the confusion, weakness, drowsiness, difficulty concentration, and so on. Now, when we think about hypoglycemia and its impact on cardiovascular outcomes, it really is associated with adverse outcomes in those persons who have what is described as severe hypoglycemia. That is an episode of hypoglycemia requiring the assistance of another person. i.e. they need to give glucagon, they need to give jelly beans or orange juice or something like that because those neuroglycopenic symptoms have impacted the person and they require help. And in that situation then, we see that if you look at the outcomes in those patients, and this is really mirrored in all the trials where patients have had severe hypoglycemia, that we see that there's a significant increase in both major macrovascular events, microvascular events, death from any cause, death from cardiovascular causes, and an increased risk of dying from other non-cardiovascular diseases, liver disease, kidney injury, skin diseases worsened. So we're not quite certain why hypoglycemia is bad, but it is bad. That's the take-home message. We don't know if it's a marker that you're just sort of body starting to get to a very brittle end stage, or if there's something about it that actually drives adverse cardiovascular outcomes. But as I mentioned, it's not, you don't just have adverse cardiovascular outcomes, you're much more likely to have kidney, liver, lung failure for another reason there. So it makes sense then, if we can use agents that avoid it, we don't need to worry about it. So what are the risk factors for it? Well, at the moment, it's generally insulin secretagogues, which are the sulfonylureas, because they directly impact insulin production from the beta cells in the pancreas, or insulin therapies. These neuroagents, SGLT2s and GLP1s, the incidence of severe hypoglycemia alone is extremely low. But when used in combination with insulin or SGLT2s, that's when it occurs. And clearly those persons who are missing meals, advanced age, long duration of diabetes, and very importantly those with more significant renal dysfunction are much more predisposed towards severe hypoglycemic syndromes. And so generally, as a rule of thumb, in persons who have a EGFR less than 45, I avoid sulfonylureas completely. So what do we do? Now, this is not sort of evidence-based. I call this eminence-based. This was Alice Cheng who came up with this schema. What she suggested was that obviously you need to ask about hypo. Have you had a hypo? Did anyone have to give you orange juice or some jelly beans? If the A1C is 8, then she says, okay, based on the glycemic efficacy of the SGLT2s or GLP-1 receptor agonists, you should just stop the sulfonylurea, or at least halve the dose. I think it's easier just to get rid of it. Patients usually like it if you substitute one thing with another. If you add on, they may not like it as much. So I just generally suggest stopping the sulfonylurea. Importantly, however, do not stop the insulin if you're on it. Okay, this is not a time with insulin. You just don't go in there guns a-blazing and say, we've got you on this new pill that improves cardiovascular outcomes or new injection. You dose reduce. So this is where I think when you're getting your feet wet in using and prescribing these agents, you may then want to call for help, get some assistance of someone else if you're not comfortable. As a rule of thumb, you can reduce the basal insulin dosage by about 10 to 15%. So fairly simple. You can pretty much do that across the board. And then as a rule of thumb, I find that most of the primary care docs are actually fairly comfortable with then modifying further on. This is not a big deal, but as a cardiologist, if you want to start using these agents, then you probably will need to reduce the insulin. If the A1C is greater than 8%, then the glycemic efficacy will not necessitate a change in the medication there. So A1C greater than 8%, put them on the GLP1, put them on the SGLT2. You don't really need to worry about their medications at that point in time. Moving forward, however, though, particularly with the GLP1s, particularly because of the major impact on weight loss, there usually does necessitate a reduction in long-term insulin dosage or modification of their other anti-hyperglycemic agents. But generally I find there that the primary care docs are very happy to do that. This is sort of their bread and butter in primary care. So that's not been an issue. In fact, most of the primary care physicians that I speak to say, yeah, we want you guys to get them on the pill. We'll follow up because our job is to look after the total patient. You fix the heart, we'll look after the eyes and the kidneys and the rest of the stuff, which means we will modify the dose moving forward. Now, of course, that's not every primary care physician. I think you need to know who the patient's seeing, but in many instances, they're happy to do it. And the reason I focus on the primary care physician is we know that if we look at most persons with established cardiovascular disease in Canada, about 17 to 20% will see an endocrinologist. The rest will never see an endocrinologist. That's partly the reason why I think it's important that cardiovascular docs see and treat these patients, because we're the ones who actually see the vast majority of these across Canada, and it's very similar to the statistics for overall heart failure. Remember that more than 50% of people with heart failure will never see a cardiovascular specialist in their lifetime. So what about heart failure itself? We've talked a little bit. How does that affect the choice of an anti-hyperglycemic agent? And I think this was clearly a game-changing clinical trial, the DAPA heart failure trial. This was, as opposed to the previous studies I mentioned where we saw a reduction in hospitalization for heart failure, this trial was designed as a bona fide heart failure trial. Persons with heart failure and reduced ejection fraction on appropriate evidence-based therapy, elevated NT-proBNP, were randomized to receive placebo and dapagliflozin. And I'm sure you've heard this a number of times, so I'm not going to go over the trial detail in any more detail other than to say that when the investigator, when John McMurray went forward to the various groups and said, okay, what should you do with the other agents? They actually didn't really mandate anything. They said, yeah, you're on a bit of diuretics. Of course you are. You've got HFrEF. They didn't suggest you need to dose modify. They didn't suggest anything further. They just said, put them on. They'll be randomized to placebo, dapagliflozin, go forth and let's see the outcomes in the trial. And in this real world setting, well, at least in this clinical trial setting, it was very well tolerated in this group of patients with heart failure and reduced ejection fraction. And clearly here, I'm sure you've all seen these curves, really dramatic reduction in the endpoint of cardiovascular death, hospitalization for heart failure or an urgent heart failure visit. But as I mentioned, the reason to suggest this is and talk about this is in the trial there was really very little instructions that were given to the investigators. It was just, yep, you're on dapagliflozin or placebo. Don't really worry about the other drugs. The list of adverse effects was extremely low in this clinical trial, extremely low. Now, of course, this is the clinical trial setting. This is more frequent follow-up than what we see in the real world. But overall, it was very, very reassuring that in this sicker population already on diuretics, agents that block the renin-angiotensin system, that there were really, really very, very, very low rates of adverse events there. And of course, the other key point here, which requires a lot further investigation, was that it did not matter whether you had type 2 diabetes or not, that the agent had a similar beneficial effect for that endpoint of cardiovascular death, hospitalization for heart failure, or urgent heart failure visit. At the moment, what we suggest, the guideline directives are that metformin remains the initial drug if the eGFR is greater than 30. You can consider the SGLT2 to prevent hospitalisation for heart failure, and perhaps DAPA to reduce or treat patients with heart failure and reduced ejection fraction. We do avoid the use of saxagliptin because of the signal that was seen in the SAVOR trial, and clearly we avoid the thiazolidinedione class because they clearly cause salt and water retention. So what about initiation in hospital? So let's say you've got someone that comes in today, what general advice do we give? So I've sort of broken it down into two scenarios, the general patient and then the patient specifically who has had a cardiovascular event. So these are all sort of general considerations that you should ask really, I think, for initiating any new drug for any patient that's admitted to hospital. Why were they admitted and what was the in-hospital course? And clearly those patients that are hemodynamically unstable, dehydrated, have significant urosepsis, labile blood pressure or hypotension, that we're not just going to initiate these agents up front. You'll wait for those to resolve, and then you may consider the use of either of these agents. What other medical issues? It may not be appropriate to use these patients. If they're very elderly, frail, and your endpoint is quality of life, then it doesn't make sense to use an agent that clearly prolongs life there, because that may not be the goal, and that's obviously, you need to have that discussion with the particular patient. If we're initiating in hospital, I think you do need to know what the other antihypertensive agents and diuretics are, and then you need to prioritise as a clinician which one you think is most important and initiate first, as opposed to just adding them all in simultaneously. And then are there particular patient groups where you may consider one agent over the other? And of course, in hospital, we generally have the luxury of knowing what the renal function's like. We can measure supine and upright blood pressures. We know the A1C, and that we know what the serum electrolytes are here. So what happens if you've got a patient that is requiring surgery? What do we generally recommend for the SGLT2 inhibitors? And again, this is not really evidence-based. This was a group of experts who got into a room and came up with what do we think were practical, reasonable suggestions to advise people as to what to do. If you're having minor surgery, you can continue on with your SGLT2 inhibitor, don't need to worry about it. If, however, you're having major surgery, major GI surgery, obviously thoracic surgery, etc., then you should definitely withhold the SGLT2 inhibitors at least 72 hours, and you need to keep an eye on the plasma glucose levels. These persons, because of I mentioned before, you've potentially predispose them towards the development of DKA because you have that imbalance between the insulin and the glucagon. You need to be very close at monitoring the plasma glucose levels. And an important point here, if you suspect the person has DKA, that they're becoming acidotic, that things aren't behaving normally, you need to check that, and you specifically need to measure beta-hydroxybutyrate, which is the level of the ketone body. Some labs will measure ketone bodies, but there are other ketone bodies other than beta-hydroxybutyrate. You need to specifically ask for and measure beta-hydroxybutyrate. I know you measure it here, but there are other smaller hospitals and labs around Ontario where when you say ketone bodies, they may measure acetone or acetoacetate, and that will not tell you that the patient is developing diabetic ketoacidosis. Now, you treat the DKA as you would normally treat a DKA. There's nothing different about that, but it's all about avoidance in that situation. However, the likelihood of developing it, if you have withheld the SGLT2 inhibitor 72 hours beforehand, is extraordinarily low. It's just, this is a point that people keep bringing up and bringing up. It's extremely low, but if you know about it and you know how to prevent it, then we won't get into trouble. Now, clearly, if you're hypovolemic or in a catabolic state there, or in those patients that have bariatric surgery, we would suggest that you wait a reasonable time frame before reinitiation of these therapies. So once you're eating again, normal oral intake, then you can restart the agent. In those that have bariatric surgery, we generally suggest you need to let the whole GI tract settle down after that, 4 to 6 weeks afterwards. And obviously, if from the cardiovascular perspective, once the agents are on appropriate and stable doses of their concurrent antihypertensive and diuretic therapy, and that there's no ongoing hemodynamic or renal function instability, that you could consider reinitiating the SGLT2 inhibitor in hospital. But again, there's nothing particularly important there. This is the same as what we would do for reinitiation of any diuretic, spironolactone, renin-angiotensin system blocking agent in our patients. So again, scenario A, are they unstable? Check the blood pressure. If there's any concerns, don't initiate. If their renal function is greater than 30, then you may consider initiating. Okay. Now, in the DAPA heart failure trial, they did not mandate a particular time frame for monitoring renal function afterwards. We just felt here that it was, if you're initiating in hospital and you're concerned, it makes sense that you should probably follow it up. Again, however, these agents are generally renoprotective and prevent against acute kidney injury. But we do suggest that if the eGFR drops, now this is the eGFR, this is not serum creatinine, if it drops by greater than 30%, which is a substantial reduction in eGFR, that's unusual. Generally suggest get a nephro consult, because this is a much greater reduction than we would usually anticipate. It may give you an idea that something's going on in the kidney that require further investigation. What about scenario B? This is the more typical scenario that you might see here. Someone's had a cardiovascular event, a stroke, hospitalized for heart failure, myocardial infarction, major adverse limb events such as peripheral vascular disease. If they have HFrEF, well then obviously you're going to optimize the standard heart failure therapies first prior to initiation of an SGLT2 inhibitor. I say that because the DAPA heart failure trial was add-on in a stable population. It wasn't done before, so I think we should be true to the data and initiate it that way. If they're stable, on stable doses of diuretics, blood pressure's okay, renal function's okay, and this is in a scenario where you're not considering doing further investigations like coronary angiography, PCR bypass surgery, then you can go down the algorithm. If the HbA1c is less than 8%, stop or reduce the sulfonylurea, or as I mentioned, that dose reduction in insulin, and then you can initiate. And as I mentioned, because it's in hospital initiation, potentially in a more unstable patient, that it's not mandated, but we generally recommend it's reasonable to get renal function followed up early on. Again, there is no good trial evidence to support this. This is just a sort of a pragmatic, simple way to moving forward. And again, the same rules again, if there's that substantial reduction in eGFR, you may consider stopping the SGLT2. But again, I don't think this is any different than the initiation and follow-up of any other person, in particular with mineralocorticoid receptor antagonists. It's really the same way in which you should address those. What about the GLP1 receptor agonists? Again, we avoid in the really sick population acutely. If they're in the ICU, this is not the time to initiate these agents. The clinical trials were all done in stable outpatients, so it does not make sense to initiate them in the unstable group. As I mentioned, if they've got gastroparesis or pancreatitis, we avoid it. You need to counsel about the nausea, and again, same rules. If the A1C is less than 8%, you probably stop the sulfonylurea and dose reduce the insulin. Because the incretin class includes both DPP4 inhibitors and GLP1 receptor agonists, we cease the DPP4 when we initiate the GLP1 receptor agonists. Because remember that a GLP1 receptor agonist, if you will, is like a DPP4 on steroids. So there's no added advantage in adding the DPP4 inhibitor in. And again, like every other agent when you're initiating, start low at a low dose and go slow with the up titration, again warning the patient about the nausea there. So last slide, a lot of practical tips, hopefully they're helpful. Very, very important time in the management of our patient with diabetes. We've now moved beyond just simple glycemic lowering to now directly impacting both microvascular complications and macrovascular complications. Because remember, with the SGLT2s and GLP1 receptor agonists, they don't just impact those macro, they also, as an added benefit, if you will, impact the microvascular complications. So now we've really got agents that cover the whole gamut of spectrum of complications of type 2 diabetes. We have two agents that clearly reduce in the non-heart failure setting the type 2 diabetes and cardiovascular disease that reduce mortality, EMPA and liraglutide. I've mentioned about what to do with insulin secretagogues and insulin pending on the A1C if you're thinking about using these agents. But you do need to know the renal function, as I said, particularly with the SGLT2 inhibitors. I think you do need to counsel about SAD/MANS. And the other important point is we don't routinely stop the insulin. You need to dose modify, but it's not just a matter of new agent equals stopping the insulin. As I mentioned, often what happens particularly with the GLP-1 receptor agonists, patients lose a lot of weight, and you often have to dramatically reduce the dose of insulin, but you don't do that initially. You need to follow up and tell the patients following that, and if their sugars start getting low, that they need to follow up with someone and dose reduce then. And what we don't really have data on is what the impact of these agents will be in combination. At the moment, really all the clinical trial data was monotherapy added on to insulin, sulfonylureas and metformin. We're now seeing some of the newer trials where we're seeing the combinations in up to 20%, but we really don't know what the combined impact of these agents will be. So with that, I'll stop. Thank you very much for your attention and take any questions.